Hello, everybody, and welcome to Therapy Thursday. Today is September 22nd, 2022. Yeah, it's still 2022. And we're excited to have everybody here today for this episode of Therapy Thursday. My name is Evan Adler. I am a physical therapist, and I represent the Community Engagement Committee here at UNC Therapy Services. Our mission is to engage with the community, provide information and services, and really kind of be there for the community as best we can outside of just doing our regular jobs as therapists in the clinic. So we're very excited to have you all here today. Therapy Thursday is a series that we developed a couple of years ago at the start of COVID, so we could continue to reach out to the community virtually where we couldn't do things face to face. So we have put together quite the library of presentations now that all live on our YouTube channel. And I'm putting those links into the chat here, so you'll be able to see those. So I invite you to go to our YouTube channel. Please like, subscribe, all those fun things. And you can also check out our Facebook page for UNC Therapy Services, where you'll find out information about other Therapy Thursday presentations and in-person events that we'll be doing, such as race coverage for larger events in the area, like Bull City Race Fest, the Tar Heel 10 Miler, and then the series of races that they have out in Carborough. Most recently, we're at the Canes 5K in Raleigh, PNC Arena. It was a great time. We got to stretch Stormy, the mascot, out, and we had a really good time. So, without further ado, I'm going to turn it over to Sara, who's going to give us an extremely topical presentation for lots of people who spend their day all day at the computer on carpal tunnel syndrome. So, Sara, go ahead and take it away.
Hi, everybody. It is so great to be here, and thank you for taking time out of your Thursday to talk about carpal tunnel syndrome with me. I am Sara. I'm an occupational therapist and assistive technology professional, originally from Connecticut, but I moved here in 2021. And if you need me, I'll be at the UNC Wellness Center at Northwest Cary on Mondays and Wednesdays, and the Hand Center at the ACC on Thursdays and Fridays. So our goals for today are to look at the anatomy of the carpal tunnel, look at what the syndrome is and its symptoms, about causes and risk factors, as well as the role of the doctor versus the role of the occupational therapist. So the carpal tunnel is a segment of our wrist that's a passageway made up of tendons, bones, and ligaments. More on the dorsal aspect, we have our carpal bones, and up top we have our transverse carpal ligament. And in between, we have tendons for our flexors and the median nerve. The median nerve is very important. It provides motor and sensory input to the wrist and hand. And it's important because the syndrome of carpal tunnel is when you get compression of that median nerve. Compression can be because of a change in contour of that carpal tunnel or a change of fluid equilibrium within the carpal tunnel. The symptoms of carpal tunnel syndrome are a numbness and tingling of the first 3.5 fingers, so thumb, index, middle, and half of that ring finger. It can be a lot of the times patients or people will report that they don't have a good grasp on items. They're dropping items frequently, things are slipping out of their hands. Really interesting is up to 80% of individuals with carpal tunnel syndrome are also reporting disturbances to their sleep. And that can seriously impact your daily activities and your routine. In fact, patients are reporting 2.5 hours less than the recommended amount of sleep, which is a ton. So there's a lot of different ways that this happens. Environmental demands is one we're all familiar with, being on computers all day long in the age of technology. Anything that puts our wrists into extreme flexion or extreme extension, so that bending forward or that bending back for long periods of time can cause compression of that median nerve. repetitively using our flexors or gripping can also cause carpal tunnel symptoms. And so you'll see that in jobs like hairstylists, where you're constantly opening and closing your hand with those scissors. An external pressure or a force right at the carpal tunnel can also cause symptoms. And you'll see that with things like mountain biking, yoga, anything that's putting pressure directly through that transverse carpal ligament, that volar side of your hand. And vibratory forces. So if you think of a construction worker who's using a jackhammer all day, or someone who's using a weed whacker all day, that vibration, that constant input, can cause symptoms. There are also factors that directly impact the health of your nerve. These are things like diabetes, alcoholism, vitamin deficiencies. Those can create the similar symptoms. Changes in the internal anatomy are also big players in the game of carpal tunnel. So if you have a fracture, a lot of the times what we'll see is when the doctor goes into repair, they'll also do a carpal tunnel release because the change in the bony anatomy can create pressure on that median nerve. There's also post-traumatic arthritis. So after a big injury, we get bony changes, and those can leak into that area and cause us to experience these symptoms. And finally, tumors and cysts. There's also change in the fluid equilibrium of the body. So normal is 2 to 10 millimeters per mercury. Anything higher than that, which we see in pregnancy, menopause, use of birth control pills, hypothyroidism, and congestive heart failure, can cause compression in that median nerve just because that fluid is really trapped in there. So it's kind of a vicious cycle. What happens is we get this chronic increase in pressure from any of those things we just talked about. That creates swelling within the carpal tunnel, which then causes the nerve to scar. That scarring will then make that nerve and make it not move as well through the carpal tunnel, and we get tension with motion. That tension with motion leads to the chronic increase in pressure, and it just goes around and around until we have carpal tunnel syndrome. There are things that predispose you to having carpal tunnel syndrome. An injury, like we talked about, fractures, dislocations, anything like that. Being in your 4th to 6th decade, as well as being of the female sex, you're more likely to have carpal tunnel syndrome. The theory behind that is that the carpal tunnel itself is smaller, and so there's less space, there's less wiggle room. Chronic illnesses like rheumatoid arthritis, congestive heart failure, those will predispose you to carpal tunnel syndrome. And environment and profession is a big one. If you're someone who's on your computer a lot, holding your phone a lot of manual labor jobs, all put pressure into that carpal tunnel. And then finally, smoking is something that can definitely impact your nerve health and predispose you. So the doctor's role, the first thing they'll do is they'll look to diagnose, and they'll do this through a couple of different ways. The first is an MRI, and they're least likely to do this because it has lower sensitivity. What the MRI is really doing is it's looking for a lesion on the nerve. It's less sensitive, you're less likely to have this happen. What is most likely is an EMG or a nerve conduction study. And an EMG is looking for actual changes in the muscle distal to the carpal tunnel, so closer to the fingertips from the carpal tunnel. Whereas a nerve conduction study is looking at the velocity of the nerve, and it's taking that velocity at the carpal tunnel and comparing it to a healthier segment up higher. And those are two really big ways that doctors will say, yep, there's an issue happening at the carpal tunnel. There's also diagnostic ultrasound, where we're looking for change in diameter of the nerve as it's entering that carpal tunnel. Once the doctor identifies carpal tunnel syndrome, there'll be some treatments. Steroid injections is a very common one, and when compared to placebos, there are big improvements that are seen. However, at around the 6-month mark, those improvements in studies are shown to go away, and so this isn't a cure, this is more of a temporary fix. Platelet-rich plasma is also being explored, and the theory is that the growth factor within the plasma is causing healing of that nerve. So in that area where it's really irritated, that growth factor comes in and kind of beefs things up. However, the evidence is really limited to support this, so you might not see it as commonly. Doctors will also prescribe gabapentin. And gabapentin can be great for a lot of things. What the studies do show, though, are at the 2 and 8 week mark, patients aren't reporting big benefits from it. This is not to say to stop taking it. This is not to say to tell your patients to stop taking it. This is just saying that it is very possible for a patient to be on gabapentin and to still come to you with these symptoms. And finally, the doctor will refer, and they can refer to either hand surgery or OTPT. So if the doctor refers to surgery, there are two types that can take place. The first is an open release, where they make an incision down the wrist, go in and cut that transverse carpal ligament, or an endoscopic release, where they go and make an incision in the palm and one a little lower down and bring their tools in and do the same. As with anything, there are risks to surgery. One of the more common risks is something called pillar pain. And pillar pain occurs on either side of the wrist, on either side of that incision. And what's tricky about pillar pain is that there's not a whole lot we can do about it. It's really a time game. And so encouraging your patient just to be patient and to wait it out, and knowing that it will eventually subside. Scarring is another huge risk, but it's something that we are very well trained to handle through lots of different techniques that we'll go over a little bit later. There's also risk of infection and injury to the median nerve. So now we'll talk about what happens when you show up at my door. So the first thing we'll do is we'll talk about the history, when it started, how long the symptoms have been going on, are there any injuries, comorbidities. All these things paint a bigger picture of what's going on. We'll talk about what it feels like to have carpal tunnel syndrome to you. So is it pain, numbness, burning? Are there activities that make it better or worse? And are you feeling it during the daytime or the nighttime? The other thing we'll look for is thenar wasting or atrophy. And as you can see in this picture, this person has a good divot in their thumb. And when a patient comes to us with a divot that big, it's a good thing to be in contact with the doctor, because that shows a pretty strong severity of the carpal tunnel syndrome. And we want to also have the doctor's eyes on that. We'll also do a physical exam. There are a couple special tests that we want to run. They're called provocative tests, so they're looking to provoke the symptoms. The first one is a Durkin's test, and what you do is you take your thumb and you place pressure right over the carpal tunnel for 30 to 60 seconds. And again, we're looking for that recreation of symptoms, that numbness, that tingling. Tinels, I think T for tapping, you're going to do a strong tap over the carpal tunnel for 30 to 60 seconds. And again, wait to see if those symptoms are recreated. Finally, there's Fallon's test, where you take the backs of the hands and place them together and give a little bit of pressure. You can also do this by taking your patient's hand and putting a little bit of pressure. You don't want to go crazy, just enough to see if it recreates symptoms. It's also very important to test grip strength, because as we know that the median nerve affects our motor component, it's going to also affect our strength. And if we can't feel as well from that sensory component, it's also going to impact how we grip our items. And we test the grip strength, we get an idea of what we need to work on in terms of rebuilding that strength. We'll also do a Semmes-Weinstein test, where we take monofilaments, which are like different thicknesses of fishing line, and we test each finger individually at each nerve distribution to determine if the person has an impairment in light touch, deep touch, anywhere in between. Once we know that, we can start to counsel and guide the patient on, okay, your light touch is a little bit disrupted, or your deep touch is a little bit disrupted. Be careful when you use hot items. Make sure you're checking them elsewhere on your body, things like that. With that sensory component, we can also see a loss of fine motor skills. And so we'll do a coordination test or a 9-hole peg test, just to see how impaired the coordination is and to set a baseline for what we're going to work towards. Part of our evaluation is making sure we're truly treating the right thing. So we do this through a differential diagnosis. So the median nerve starts in our axilla along with our brachial plexus. So we want to rule out anything like thoracic outlet syndrome. So we can do that with a quick bruise test, where you bring your arms up, Have them open and close their hand 30 to 60 seconds. Look to recreate symptoms. The next would be ruling out cervical spine disorders like radiculopathies, and you can do that with a Spurling's. There are also things like polyneuropathies. Is this coming from CIDP or diabetes? Making sure that there isn't another cause. Ruling out upper motor neuron diseases and proximal lesions. So we want to make sure that it's not a double crush syndrome where it's coming from the ligament of Struthers or the bicipital aponeurosis. So making sure that where you're treating is truly where we should be targeting, because if we're treating down at the wrist and it's really up higher, we're not going to do much good for our patients. Now, there are a lot of treatments that we can do as OTs. First is bracing. You want to be braced in a neutral position. So right down the middle. And what it's doing is preventing that extreme flexion and that extreme extension. This is most commonly done at night. There is someone where you know yourself and I flex all day long, or you know that your patient is someone who's doing a lot of repetitive tasks, you can recommend it during the daytime during those tasks. Bracing is another area where we need patience because the relief isn't felt right away, according to the studies. Usually it takes between 6 and 12 weeks for that relief to be felt. So it takes a long time, but it really does work once it gets going. Median nerve glides are manual techniques that change the condition around the nerve. So what it does is it takes that nerve and in the area where there's scarring, it gently glides and flosses it through so that we're opening up that space again. Now, as you can see in the picture, this patient is fully extended. That might cause extreme pain for someone. When you're doing nerve glides, you never want them to feel extreme pain. You want a gentle pull, and as time goes on, you can progress that a little bit farther. There are other types of nerve glides that are located closer to the hand, and so that is just bringing the hand up, bringing the wrist back, spreading those fingers wide, and holding that position for 5 to 10 seconds. This might create some of that numbness and tingling. If it does, back off just a little bit. When it was compared to just regular exercise therapy, the use of nerve glides increased results for pain and function. So it made pain better and it improved function at both 1 and 6 months post-intervention. So after doing this, it carried over, which is really important. We'll also do manual therapy. So the first is stretching that transverse carpal ligament. And you want to do this slowly and gently and very mindfully, knowing that the median nerve is right under there. So we don't want to press too hard. We don't want to pull too hard. So in the top picture, it shows just very gentle, thumb on either side, gentle stretch. This will also be something you can teach your patient or you can do at home yourself. In the bottom picture, you can see the patient is against the wall and is gently pulling the thumb backwards. You don't want to pull very hard. It's just a very gentle lift of the thumb. And it's again to stretch that transverse carpal ligament. The therapist can also bring the patient through median nerve glides, as well as carpal mobilization. So getting that proximal row moving, focusing on the scaphoid and the hammy. So helping to stretch out that space, work some edema out. Taping is a really cool tool to have in our toolbox. What it does is it decompresses or it cues. So one or the other, amongst some other things. But with carpal tunnel syndrome, it's been shown to improve test scores, improve provocative tests, make the symptoms overall better. And if you want to directly address the carpal tunnel, the picture on the right side, or the black and blue tape, is your best bet. But sometimes we have patients where they do repetitive tasks all day long. We really want to brace them, but either because of their job or because of other factors, they can't be braced during the day. You can go ahead and use the other taping method to cue them a little bit more into extension. And that's that red and blue tape right there. And it's just a way to help bring that wrist back up, try to cue it towards neutral if there's someone who flexes a lot. Ergonomics is a huge part of the OT world, looking at your day-to-day activities and making sure that they are serving you to the best of their ability. Repetitive tasks are one thing that can really trigger carpal tunnel syndrome, so encouraging the person to take frequent breaks is really important. Every 20 minutes, stopping for a couple minutes and just resting your hands, maybe doing some median nerve glides. Hands-free devices are huge in this day and age. Your AirPods, your Google Buds, whatever you've got to avoid constantly grabbing your phone and pressing it, because it often sits right in that carpal tunnel area. Ergonomic tools are fantastic because they're built with the wrist and hand health in mind. And you can get these. OXO is a brand at Target, or in the picture with the mouse, they make ergonomic mice where it keeps that wrist in a neutral position and you're using your larger muscles to navigate. Reducing vibration is a big one, especially I know a ton of people around here. I can't tell you how many of my patients are mountain bikers, or are people that do things that drive a lot or have a lot of vibration through their hands. So reducing vibration through silicone. So that is biking gloves with a silicone insert, or WAGs, which stand for wrist assured gloves. They really help if you're doing yoga a lot. I have a pair myself that I use. It takes that pressure and it disperses it away from the carpal tunnel. And so it just promotes the health and longevity of your hands. So we also see patients post-operatively. And so treatment looks pretty similar, but there are some areas that we focus on a little more heavily. Strengthening, we want to make sure that we get patients back to their preconditioned state as best as we can, or at least within the norms. So doing putty exercises, hand grippers, trying to bring that strength back. Dexterity is another one. So lots of fine motor coordination, lots of little itty bitty tasks to get that fine motor coordination back where it should be. Scar management is a huge one. We really want to avoid that scar tissue, that sticky scar tissue, from getting into that area and impacting that median nerve. So we do this through a couple ways. Massage is one. For 5 minutes twice a day. It sounds like a lot. However, you can do this while you're watching TV. You can do this in a waiting room. You can do this as a passenger in the car. You can make it fit into your day. But no less than 5 minutes twice a day is recommended, and just circles over the scar, pushing up, pushing out, spreading the scar, really doing everything you can to make it mobile. Silicone strips are also really interesting because what studies have shown us is that scar tissue is really chaotic and it looks like a bird's nest. When you add silicone to the top of scar tissue, what it does is it helps to reorganize and it flattens everything out, makes it smooth, less chaotic. So we'll recommend silicone strips like Scar Away for our patients. Desensitization or even resensitization is a huge one. You can do this through massage. So if the scar tissue is really, really sensitive, massaging the area will help decrease that sensitivity. And texture immersion for desensitization or resensitization. So getting a rice bucket, I like to have my patients get a Tupperware of rice and play around in it throughout the day. You can heat it up a little bit to add another, like a thermal layer to it. You can hide different items to have them search for it and really test their sensation. So the key points, carpal tunnel is something that's really common. It impacts almost 4% of the population. It is compression of the median nerve at the carpal tunnel, and there are lots of both intrinsic and extrinsic factors that are playing a role. But fear not, there are lots of treatment options, and so you can always come on by and we'll help you out. Are there any questions?
Sarah, thank you so much. I don't see any questions in the chat just yet, but we're going to leave this open for a little bit. So I know that I've had some issues with my wrists. I know that in the past, doing push-ups has been very challenging for me because I have some limited wrist extension. And then also riding my road bike, I get some numbness through my hands. So this has been really informational for me. Do you find that patients have a lack of range of motion at their wrists? Is that something that typically comes along with carpal tunnel syndrome?
Sometimes, if that nerve is really, really tight and they're having a hard time getting into extension because that gliding isn't happening, it can limit them just from a pain standpoint. But in terms of like joint integrity or anything, not really.
Okay, cool, cool. All right. Well, while we're waiting for anybody to drop in any questions there, I'm gonna put those links back in the chat here again for our YouTube channel and for our Facebook page. So, if you do have any questions, you can always go to our Facebook page or to our YouTube channel, and on there because we see those comments as they come in. Um, and as I'm talking here, we did just get a question that came in. It says, can a person redevelop carpal tunnel syndrome after having surgery 20 years prior?
So yeah, I have seen that quite a few times. In my experience, there have been some patients that have come in and the EMG shows again that there's carpal tunnel syndrome.
Is that typically from a buildup of scar tissue in the area, or do you know why that may happen?
That would be my guess, is that there's a buildup of scar tissue, especially 20 years ago. People weren't getting sent to OT to do the scar management, to do the rehab. And so scar builds up. It can also be if there were any fractures in that time, any injury to the hand, any arthritis changes in the wrist can also lead to that.
Gotcha. So now I know that for at least for physical therapy, and forgive me for not knowing this, Sarah, for PT, you do not need a referral for physical therapy, particularly here in the state of North Carolina, if you have commercial insurance. So if you do have Medicare, that's a different story. But if you have Blue Cross or Aetna, United, you do not need a referral to come in for physical therapy. How does that work for OT? Can people come on and contact you directly, or do they need a referral?
So people can come direct me or contact me directly. Um, Again, it is with the commercial insurances. We are a direct access,
Great,
I think a newly direct access profession.
excellent. So I think that's one point that very often gets overlooked, that you feel like you need to go to one provider, then to therapy. If it's something that we know that we can get right to for therapy, you can come right on in. We did have a question that came in that says, on average, how long do patients take to heal? And I'm not sure if that's a after surgery or just from onset of some symptoms. But can you address that?
Sure. So from onset of symptoms, it's really patient dependent, but it can take anywhere from 6 to 12 weeks for that bracing to start to work. So it can be a couple of months before you start to feel benefit from it. After surgery, it can be a little quicker. Usually there's a 4-ish week period where we're not doing much with the hand, um, or that the patient isn't supposed to be doing much with the hand in their day-to-day life. But beyond that, they heal pretty quickly. So I would say in both cases, it can be a month to a couple of months.
Great. All right. So let's see. It's about 1 o'clock here. If we have any other questions, please feel free to drop them in the chat. Now would be the time. Um, but I do want to thank Sarah for an excellent presentation today. Really, really interesting, and I know so many people that have issues with this. So it's good to know that there are treatments available. And thank you all for joining us for Therapy Thursday. Our next one is going to be in a couple of weeks. We're going to have two of them in October, as it is audiology month. So we're going to have two topics: one on tinnitus, kind of ringing in the ears, and the other one is going to be about early hearing loss, particularly for pediatrics. So that'll be really interesting. Then in November we will have one talk, and that's going to be from some of our pelvic health physical therapists, and I believe the topic is going to be on constipation. So that will be an interesting one to deal with as well. I don't see any other questions coming through, so I'm going to take this opportunity to thank everybody for coming. Please visit our YouTube channel or our Facebook page to find out more information. And thank you for joining us for Therapy Thursday, and we hope to see you again. Thanks, everybody.
Thank you, everyone.